Thank you, chairpersons. We are moving on to the next keynote address for the day. It's going to be by Dr. Krishna Seshadri. So the chairpersons are Dr. Srinivasa Murthy and Professor A. Sundaram. We request them to come to the dais, please. Dr. Srinivasa Murthy will be honoring Dr. Krishna Seshadri by endowing a shawl on him. Professor Sundaram will be presenting a shield to Dr. Krishna Seshadri.
Thank you very much. When Dr. Shanmugam called me and said, we want you to follow Dr. Mohan, I've been telling him that I've been following him for all my life. It's really an honor to be here. I just want you to know that this is an industry-sponsored symposium, so be aware of my conflict of interest, but I will try to keep it as more about obesity and less about the drug. So let's look at it somewhat differently. First, let me give you my definition of obesity. I think we need to relook at the definition of obesity. Obesity is a disease or a condition characterized by an excessive accumulation of fat with also an altered distribution of fat leading to its dysfunction and complications. I've been brought in three things here. One is there's an excessive accumulation of fat, which means that our current way to diagnose it, which is a BMI, is only an approximation. The second is there is also an altered distribution of fat, which means that it's not sufficient to show that the fat is more. It's important to show that the fat is abnormally distributed, and that means that we have to change the way we look at it. So I'm going to tell you that what you need to do is do both. A BMI at this point of time as also a waist by height ratio, which is much better than other things that we have. The third is that this fat, when abnormally distributed, dysfunctions. And we have multiple ways of showing fat dysfunction. The simplest way is to show there's inflammation, or there is fat in the liver, or any of the others. Lastly, this causes complications. How does this cause complications? There are three kinds of complications. One is mechanical complications that are caused by just the excessive accumulation of fat. This is obstructive sleep apnea, this is arthritis, this is back pain. Second, there are metabolic complications. The most important of the metabolic complications is diabetes. The others include a whole bunch of other things, including NASH. The last important complication is a psychological complication that occurs in all of these. So just remember that obesity is three things. One is an excessive accumulation of fat, an altered distribution of fat, altered function, resulting in altered complications. Now, why is it difficult to lose weight? And again, I've spoken about this in many places, but to simplify it, when we eat, there are two important components. One is the homeostatic need to eat, which means that we are eating because the body needs us. This is a metabolic issue, which is controlled by your ventral hypothalamus. There is a balance. One, orexigenic hormones and orexinogenic hormones. What is really happening there is an alteration in the orexins and anorexins. Now, the second part, which is the most important part for us, is that eating is also a reward. We eat because it makes us feel good. That when we eat, these reward centers are stimulated. And these reward centers are feeding into the hypothalamus and saying, I know you don't need this food, but go ahead and eat because it makes me feel well. There are two hormones involved here. One is the endorphins, which gives you that liking for food. The second is dopamine, which motivates you to go and get that food. So the simplest way to look at this is, we eat because we need it. That's homeostasis. But we eat because we like it. That is reward. Now, because our reward has become more over a period of time, we eat a lot more. The second part of this reward system is it's also controlled by other things. One, I keep telling the way to think about it is think about it philosophically. The Indriya, the Mana, the Chitta, and the Viveka. So the senses, you're thinking about food that is being cooked. You know that when you go home today, they've actually made your favorite food. You start thinking about it, you want to eat. That's hedonic. That's visual. But the sights of food, the taste of food, but also you're learning with food. For example, if somebody says, we have puri idli today, you remember how your mother made it some years ago, and that system becomes a reward. You know what, my mother used to make it, I want to go take it. It's the same for aversion. Oh, my mother always gave me only idli, therefore I don't want to eat it anymore. But there is an aversion and a reward system that is created that helps you understand and makes you eat. Also, there is a genetic component. For example, the Eastern Europeans and the Western Europeans, their taste receptors are not as high for sweet as for us. There are also gender differences. For example, women crave sweets a lot more than men. But also, in women, the craving for food is also depending on the catamenial cycle. Lastly, in women, because fat is such an important requirement for pregnancy, the very act of sexual intercourse actually creates an environment where more fat is stored. So just to give you an overall, food is between a reward and the homeostasis. The homeostasis is actually controlled long-term by GLP-1, short-term by ghrelin. Reward is controlled by the action of GLP-1, the various hedonic inputs, the vagus, and the supratentorial, which is the hypothalamus, the amygdala, all of these into this. Now, how do you break it? The best way to break it is by practice. Abhyasanato kaunteya. Learn to control your mind. Doesn't happen, right? It takes several janmas to learn to control your mind. So how do you do that? The first simplest thing today that is available for us is, the best thing that's available is bariatric surgery. The most effective treatment for obesity, the most effective treatment for diabetes also, people may disagree, is actually bariatric surgery. Whether it is drug reduction, whether it is absence of insulin, whether it is remission, in each of these, bariatric surgery has done a lot more than any others. But from that we have learned that medications work very well. The medication that works at this point of time fantastically are the GLP-1RAs. How do these work? They work exactly. Why did I spend so much time about reward and homeostasis? They work because of this. One, they work at the homeostatic level by resetting the hypothalamus towards the anorexins. This is the first part. But what we have learned over a period of time is by working at the level of the brainstem, right? The NTS is where nausea takes place, but right next to it is a center where, near the substantia nigra, that has CGRP neurons. That's where this starts. And there, and that's very close to the blood-brain barrier, the GLP-1RAs work there, and then they create a dissociation between reward and craving. When they create that disarray, food no longer becomes a reward. So how do GLP-1RAs work? One is they reduce your actual amount of food. That's satiety. I'll talk to you. But more importantly, they remove that association between your craving and the reward sensation. Now, how do we know this happens? All our patients are telling you. But very interestingly, we know that these drugs reduce addictions. So you'll suddenly find your friendly psychiatrist calling you and saying, can you give this to somebody who loves alcohol so much that if you put them on a GLP-1RA, it comes down. People are looking at it for smoking, right? Interestingly, it also reduces your libido a little because it reduces sex as a reward. So each of this tells you that one of the things that works is it's working through the corticolimbic pathways that provide food as a reward. So two ways, one at the hypothalamus, the second at the level of the, closer to the NTS where it works through the reward centers. So when it does this, three things happen. One, your craving for food comes down. That's a reward. Second, you may get an aversion to certain kinds of food. Second part. Third is satiety. Because it slows its GI emptying, it also works through the gavus. You feel full with smaller amounts of food. So these are the things that are happening when you take a GLP-1 RA. The amount of food comes down, the reward sensation comes down, you have aversion to certain types of food. So you'll find some patients saying, in a sweet, avlo aasa doctor, paatale kovam varudhu. For a lot of men crave salt. Munadi or mixture paata, vaangama varamaten doctor, I feel completely bad. But the others, what will they tell you? Look doctor, kunju saapta kuda, I have vomiting. And that's why when they overeat, because this is very close to the NTS, and it actually also works on the, this thing, you get vomiting in some patients. Remember, none of these are GI side effects. These are central nervous system side effects that seem to work towards the GI. So it is pretty much this thing. Now there's something else. There's something beyond all of this, and that is the presence of GLP-1 receptors in the heart, not in the liver, but where it works very well, in the heart also, where we know that there are very interesting things that are happening that these cause them to be very, very cardiovascular effective agents. So let me move on, and I'm going to tell you, this is what I talked to you about. Now, is there data to support all of these? The STEP study is a study that has looked at semaglutide in obesity. And there, it has shown again and again the improvement with some of this. So, oral semaglutide is the pioneer study. The sustain is the 1 milligram semaglutide. The higher dose, which is a 2.4 milligrams, is a 2.4 milligrams as the obesity dose. In addition to this, if you look at this point, this is the ESSENCE trial. The ESSENCE trial is a very interesting trial because the interim analysis shows that for the first time, other than the T3 receptor agonist, for the first time, you have a drug that seems to reduce fibrosis of the liver. So the 4 to 3 has still not been released, but when you have F3 fibrosis, Dr. Mohan was talking about ABCD, I think we should add an E and an F differently, the E being the EGFR, but the F being the FIB4 score. So it does reduce fibrosis, and for the first time we have data of reduction of fibrosis in MASLD. Now, this is a step 1 trial. I won't go into each of these trials, but tell you what we are seeing with all these drugs. One, when you talk about weight loss, in the past we used to talk about 5% weight loss. But today, what we realize is that the greater the amount of weight loss, the better. The second, there is a continuum of benefits with weight loss. I'm going to give you a very simple way to look at this. What is this 15% number people are talking about? When you say, I have lost 15% of my weight, you have lost 30% of your intra-abdominal fat. When you've lost 30% of your intra-abdominal fat, you have lost 66% of your hepatic fat. Without hepatic fat, there is no diabetes. Without hepatic fat, there is no epicardial fat. Without hepatic fat, there is no peripancreatic fat. So when you reduce hepatic fat to 66%, many of us would probably lose our diabetes. That's something that you see with these drugs. So this 15% is a number that comes because of this particular data that's based on MRI studies. But over a period of time, what you want to remember is that even some weight loss is good, and a continuum of weight loss is better. The benefits accrue with each amount. At the level of 12 to 15%, your beta cells are functioning as if there is no weight on it or a load on it. The second thing is that in these drugs, these weight loss is in a majority of patients, and a significant number of patients get higher amounts of weight loss. So up to 20% of patients with these drugs will have a weight loss of 15 to 20% or more. This automatically means many of these supportive endpoints come down, but I want to spend time on it. Now the big question is what happens and how long does it take to happen? Two things are very interesting. The weight loss is sustained. It lasts for a long period of time. It plateaus way up around 68 to 72 weeks. With tirzepatide, it's around 80 weeks. So it takes unlike the SGLT2 inhibitors, where at the end of 3 months you stop getting any more weight loss, here the weight loss is sustained, it occurs for a longer period of time, and it lasts for a much, much longer period of time. Now, the second part is that this weight loss, when you stop it, you regain it. While people keep pushing on it and saying, oh, it's a subscription model and therefore you have to take it for the rest of your life, I'm going to tell you something else. Now, we talked about, right, the viveka, the chitta, all of that. Now, the way I look at it is, you take a drug, the drug is going to remove your past sins, your past karma is going to go away, your fat is going to go away. But this is also an opportunity for patients to get a motivation. When do you give a crutch? You give a crutch and the patient requires it the most. You've given the crutch. Now you tell the patient, look, I'm helping you now, but you now learn discipline. Now the drug is giving you an aversion, but you train yourself to eat less, to not think about food every time. Do not think that you need that snack when you go to bed, and learn it over the next 60 to 80 weeks when this drug is going to be given to you. And then, when you try stopping it, you will realize that while there is weight gain, not everyone gains all the weight back. Which means that is there a finite part? In my view, and remember this is my view without evidence, that there is finite part, but this is looking at various studies which show that there are a certain percentage of patients who do not gain more than a certain amount of weight back because they have learned the lifestyle changes during these 70, 80 weeks that allows them to be complication-free for the rest of their life. I also think that you can taper it down rather than abrupt stopping or just leaving it on this thing. The last part of what I want to talk about is, I don't want to get into it, is the benefit. The SELECT study is a very interesting study because it tells us two things. One, that obesity is associated with cardiovascular outcomes irrespective of diabetes. This is one bit. But so far, we've not had real data saying that when you reduce weight, does it improve outcomes? What the SELECT study tells you is something very interesting. Remember, these are overweight patients who were randomized to 2.4 milligrams of semaglutide versus placebo. And what is interesting is two things. One, there is cardiovascular benefit. In patients with established cardiovascular disease, weight loss improves outcomes. Second, the benefit occurs even without substantial weight loss. Meaning, remember I said these drugs are present in the heart, the receptors are present in the heart and other places. So there are off-target benefits that improve these outcomes irrespective of the weight loss. Second, it also reduces renal dysfunction. Today, GLP-1 RAs are a pillar for heart failure. Therefore, these drugs are very, very important part of our armamentarium. We need to learn to use them. But ultimately, remember, to go back to this, Dr. Mohan was talking about primary and Dr. Sheshaya was about primordial prevention. One of the ways to prevent the diabetes primordially is to prevent progression of obesity, right? And how do you do that? You stop dissociating, stop associating food as a reward from childhood. You come first in the class, I'll take you to a restaurant. Stop that behavior because food being a reward is the most important cause of obesity. Second, you reduce weight, you prevent diabetes. Remember that obesity precedes the onset of diabetes by about 10 years. Third, talk to people about wellness rather than illness. But lastly, when patients require it, don't be afraid to treat obesity with a drug. You should treat it because it is a disease characterized by increased fat distribution. Going back to my definition, a disease characterized by increased fat distribution that is abnormally distributed. A disease characterized by increased fat that is abnormally distributed, that has abnormal function, that causes complications that could be mechanical, metabolic and vascular, or psychological. the real epidemic in this country is obesity. It may not be BMI-based obesity, it's mostly distribution-based obesity. And that's the proximate cause of most of our problems. Thank you for your time. I really appreciate the honor. Thank you so much.
Sir. Thank you, sir, for that wonderful lecture as usual. I think Krishna sir is one of the few people in the country who can bring science and art and philosophy and our ancient karmas also. I think most of us started thinking about old karmas now because you brought in that. And it's open for discussion now, and we have exactly 8 minutes for discussion. Okay, so to kickstart the discussion part, I've been part of many clinical trials starting from Sustain 6 for semaglutide. We have something called CSRS scoring in the clinical trials, which is a candidial suicidal tendency scoring, where we do it in every visit, which is to the site, that is to our center. Now, my worry is, end of the day, as you said, karma, rewards, all that, we live for that pleasure, for feeling good. Like yesterday, I was asking for podi idli, ghee idli, all that, including Dr. Sunil Gupta was enjoying that. Now, if we stop that, what will happen in the long term? So what is the longest evidence we have regarding this? Don't we get depressed because I am fond of clothes, a watch, or a food, and I don't want that. So what will happen next?
You'll get mukti.
That's a good one.
But having said this, I think it's an important thing. One is, it's the question is also very important because in the past, we've had drugs that have worked on certain receptors, for example, the endocannabinoid receptors, sibutramine, rimonabant, that have actually been associated with an increased amount of depression, but more importantly, suicidal tendencies. So it's a very important question. So if somebody is so depressed that they remember that obesity itself causes depression, so you need to separate it out. But if somebody has suicidal tendencies, I think these drugs should be avoided. There is no signal. We now have GLP-1 RAs for now almost 15 years. We have GLP-1 RAs at a higher dose for at least now 7 years. So at this point of time, we don't seem to have a signal for suicide. Having said that, if somebody has suicidal tendencies, I would not do it. Now, I find it very difficult to separate out eating from the karmic bit. But it's important to train ourselves that the purpose of eating is to sustain and not the other way around. Because when we think that we live to eat, then it does become a problem. But remember also that this is not something that has been around for centuries. That this food as a social construct, food as a reward, food as something that is important part of, is all a 100-year construct that started with World War I. I've talked about it in other fora about how Crisco and Dalda came, how peanut butter came, how the oils changed. But for example, many people will remember that one of the reasons we have idli on Diwali is that it's probably the only day it would have been available for many people. In fact, mutton used to be available only on Diwali for many people. Yes. So we just went and overcorrected ourselves. Need to pull it back. You should get the next stargazer. You and I will talk about it. But if that is the only obsession in life, then it needs to be cured. So anything more than an excess becomes a disease. So I think that's how it is. You can have your podi idli, but you can't have podi idli for breakfast, lunch and dinner.
Sir, I have one question.
Yes, ma'am.
Yes,
Sir, sarcopenia is one of the side effects of semaglutide. So should we give it along with any kind of protein supplements when we are giving semaglutide? Sir?
Okay, I'm going to give you, I hope some of these companies are not here. First is, this protein supplement is the biggest scam ever invented. It was first invented in all these various gyms where they were making money. Now it has become this thing. Indians have lived a protein deficient diet for many, many centuries, and we have come out better than most other people. Now, is sarcopenia feasible? There is any time you lose weight, you're going to lose both muscle as well as fat. But remember that you will end up with all these drugs, it's been very, very well shown that you lose more fat than muscle. The non-fat loss is two parts, a bit of muscle as well as the interstitial tissue. So what do? One, tell patients that you should, first don't give it to patients who have sarcopenia. For example, they have very uncontrolled diabetes, they are losing weight, their ankle thing is less than 32 centimeters, their hand grip is 10 kg or less. Don't give these drugs. Second, when you want to give it to other patients, make sure you tell them do resistance training. All you have to do is get a TheraBand or a bottle of water and start pumping some weight, it takes care of it. Now, if you really want to know about a drug that prevents sarcopenia, don't tell everyone, it's pioglitazone. Really want it, add a small dose of a glitazone, it will prevent muscle loss.
Thank you, sir.
No, this view about optic neuropathy, it's about optic neuro, this thing, we need to distinguish two parts. One, any GLP-1 RA can worsen proliferative diabetic retinopathy. This is well known. You can give any kind of excuse, but it is well known. People say it is because of the rapid reduction in the glucose, but we don't know. Second, the non-ischemic anti-neuropathy is a different ballgame. The literature is not clear, but I think the simple way to think about it is that the incidence is rare, but we should think about it as 1 in 10,000. That's the way to think about it. 1 in 10,000 patients on a GLP-1 RA will get it. There are no ways to predict it, although if you have a cup disc ratio of less than 0. This is what I do in practice based on just the information that I have. If the cup disc ratio is less than 0.2, I don't start. So we do a fundus photograph. Our photograph is AI based. If the fundus cup disc ratio is less than 0.2, I tell them to go to an ophthalmologist, get an OCT, and then come back. But I don't start them on a GLP-1 RA. There is no way to predict it otherwise. Tell the patient, this is a side effect. If you come with eye features, let us know. That's the only way to do it.
Sir,
I think SSL, sir, Rangarajan, sir.
This study has been done for how many years, sir? Whether it's 5 years or 4 years or 3 years.
So all of these studies are event-driven, meaning...
Is it going on still?
Which there are many studies that are still going on.
No, all these studies on GLPs. Whether it is SEMA or whether it is
There are innumerable studies that are still going on. If you go to the CTRI site, you will find RW is going on. You have the ESSENCE extension study going on for SEMA. With tirzepatide, multiple studies are going on. Remember, but each study is what is called event-driven, meaning it's not like the past where you would have Framingham for 30 years or 40 years. That means, let us say I'm doing a study and I say that to show a difference between 1 and 2 groups, I should have had, let us say, 400 MIs or 400 cardiac events, which is a MACE. That's usually the cutoff. So there is, for example, this would be a 3-year study, right? Select. So at the end of it is, but it's when they say it's a 3-year study, it's not a 3-year study. When they have, for example, gotten 621 MIs, then the study is stopped. So it's an event-driven.
Yes, sir.
The rebound phenomenon is said to be only 6%, sir. Rebound phenomena of gain weight is only 6%.
I don't know about that. That may be right, but the way you look at the thing is about 19% will gain more than 5% when you stop the drug in about 6 weeks.
So we'll have last question from SSL. For lack of time, sir. Rangarajan, sir, you can face to face, you can.
It's a wonderful lecture. I just want to ask you, I am very fond of seeing the food bloggers video. They eat so much, like Mark Vian keeps on eating, but he's so miserably thin and wiry. There's one Sapat Raman here in South India. He eats 30, 40 idlis. How is that they remain so lean?
They chose their parents wisely, sir.
No. I think you must study them. You must study them. What is exactly happening to that
Metabolism, probably BMI.
If you really could understand that, somebody should work on that. That's what I really.
No, there are some studies that have happened. For example, but most of these are in vitro. One is the OXPHOS rate. For example, I'll give you a simple example. I'll use a drug as an example. the modern glitazones, they work by delaying the entry of pyruvate into the OXPHOS cycle. This is one. Second is the rate of mitophagy that is present in many of these. Many of this is a mitochondrial phenomenon. We have so little data, but things are accumulating that there are people amongst us who have greater rates of mitophagy, who have a greater metabolic rate. Their T3 receptor in their livers are working differently. But the smartest way for next time for you and I not to gain weight is to choose our family wisely.